Okay, so now we're going to get into the mathematics behind Bayesian reasoning. Not heavily, but enough that I hope it helps you remember the meaning of the various concepts and to be better able to use them. I'm going to show you the math, or the maths, as Dr. David or Dr. Catherine might like to say, and I'm going to then give you simpler ways of approaching these problems to make it hopefully very useful when you're in the hospital, in the clinics, seeing patients. Okay? Okay, getting into the math behind Bayesian reasoning. So I want to reiterate, we're doing this as a series of short talks, trying to keep the learning points very simple. And to me, the most important thing about these is not the math. It's much more important to understand the concepts behind what we're doing than to understand the actual calculations. And I'll show you why, that there's some tools we can use instead of working out big mathematical formulas. That being said, hopefully it helps you guys understand the concepts if we go through the math in a little bit of detail. So hear me say that I'm not looking to make this very complex and very difficult. I'm trying to increase your understanding by covering the mathematics part of it so that you feel more comfortable and confident in your understanding of the concepts, and you're able to use those. And there are tools that can help you that don't require you to use lots of detailed math. Okay, so this goes back again to the Bayes' theorem that we already explained. So I'm not going to go over that again, other than just say, here you have the conditional probability of H given E, right? Your hypothesis given the evidence coming from new data. See this slide depicting Bayes' theorem. And the only thing I want to really point out again is here is the conditional probability of H given E. The probability your hypothesis is true given some new evidence. The E part down here. Okay. And on the right side of the equation, you have the probability of H times the probability of E given H, okay? And just take a second and think through the implications of that. In other words, if H is true, how likely is it that E is also true? And you multiply that by the probability of H, you're getting that multiplier of what the probability of your hypothesis being true is. You're dividing that by the probability of the experimental evidence being true no matter what is the situation with H, right? So these are, in a sense, two independent factors in the equation. The probability of H, how common is H? The hypothesis, how common is it for the hypothesis to be true on its own? How common is it for us to get a result, a particular result from a test? And you divide the probability of it happening all the time by itself by all the positive test results, and you're looking for a correlation that would establish that H is, the probability of H is conditional on the probability of E again. So, do you have to understand that? No. Again, just look at it. You're looking at the situation where you want to know, is your hypothesis true? What's the probability that my hypothesis is true given another variable that has an impact on the likelihood of my hypothesis? The conditional probability of H being true given that E is true or exists. Okay, that's probably enough on that. If you don't understand it at all, don't worry about it for now. Spend some time thinking about it. I think that's important to try to work it through in your brain, but you don't have to understand this in depth to be able to use this information. Okay, so let's talk about deriving Bayes' theorem. Again, it's all designed all of this is designed to give you an understanding of what's going on. You don't, I hesitate to get into this, but at the same time, I think sometimes in trying to keep things very simple, we oversimplify them and we don't give you enough basis upon which to understand the concepts. So this is just out of a desire to help you understand basically what's going on with the math so that you can use the concept more confidently. Okay, I'll just keep saying that over and over again. The math is not the point. Deriving these equations is not the point. Understanding the concepts so you can use it is the point. Okay, so here we see that the first line shows that what's the probability that both A and B are true? Okay, and this is equivalent to the probability of A given that B times the probability of B. And again, if you stop and think about it, that intuitively makes sense. For the same reason, that is equal to the probability of B given A times the probability of A. Okay? Those are all equal. Okay, the probability of A and B is equal to the probability of A given B times the probability of B. And also equivalent is the probability of B given A times the probability of A. And again, just insert actual circumstances here. What's the probability of having, let's go back to that streptococcal pharyngitis example, strep throat, if your, say, rapid strep test is positive, B. Okay, the probability of having sore throat, A. The probability of having a rapid strep test, positive. Well, you want to know, like, what are the probabilities of each of those things happening, and then are they dependent upon one another? Right? Okay, so taking this first line, we now go to the second line here. What is the probability of A given B? All you're doing is dividing both sides of this equation by the probability of B, right? So you divide this, the probability of A given B, by the probability of B. Therefore, it cancels out the probability of B. You're just left with this. And on this side, again, dividing by the probability of B, you get the probability of A and B divided by the probability of B. Okay? If you perform the same operation on both sides of the equation, it remains equivalent. Now we're going to deal with this probability of A and B piece, right? And we're going to use what we figured out up here to substitute in. So we figured out that the probability of A and B is equivalent to the probability of B given A times the probability of A. Okay? So that's where you get to the right-hand side of the Bayesian equation, the Bayes theorem, here. The probability of B given A times the probability of A divided by the probability of B. All right here, and that is equal to the probability of A given B. Okay, that may not help you. If you think about what the A's and B's stand for and what each term of the equation signifies, if you take time to do that, I think it's really helpful when it comes to understanding what we're talking about with Bayes' theorem. But nonetheless, again, my goal is not to have you guys calculate a bunch of equations. My goal is for you to be able to figure out how likely is your diagnosis given the testing you did, that sort of thing. All right, so let's look at the equation again in a different light. And again, this is all towards you understanding what does each part of the equation mean? What does each part of the equation stand for? Okay? So this is the overall thing we're trying to figure out. The probability of A occurring given evidence B has already occurred, right? What's the probability of this diagnosis we're considering knowing the test result we obtained? Okay? All right. So let's take it term by term, I suppose. The probability of B given A. Okay, this is the probability of B occurring. The probability of the diagnostic test being positive for disease given evidence A has already occurred. Again, if somebody has the disease, how likely is it that the test was positive? Okay? Over here is the probability of A occurring. And how common is the disease in the population you're looking at? Okay? And the probability of B occurring is how common is a positive test result for that disease? And this may seem all very theoretical. We will do some concrete examples in the final lecture segment, but I wanted to look at this in a little bit of, take a little bit of care to go through each part of it first. Again, I just want you to understand what the equation is basically indicating, okay? You don't have to really know how it all fits together, although I think it's really cool and awesome that this guy figured this out, a long time ago, hundreds of years ago. But nonetheless, I do want you to have some basic understanding of what's going on here. Okay, so if we look at what this means in clinical terms, this is a more helpful way of looking at it. So here you have what we're looking for is the posterior probability, the post-test probability, okay? And that is after we've obtained our testing, how does that, what does that mean about the probability of the person having the disease? Okay, that's what we're using testing for, is to make sure that we have the diagnosis correct so that we can give the correct treatment. Okay, this here, the probability of B occurring, given that A already occurred, is the likelihood part of the equation. And we're going to come back to likelihood ratios. It's something that you may not have been exposed to yet, but it's one of those things that is super important, just like sensitivity is important, just like specificity is important, just like predictive value, both positive and negative, is important. The likelihood ratio is very important. So we'll come back to that in a minute. A is the pretest probability, the prior probability. In other words, I have a patient who is in a population at risk for a disease. What's the likelihood they have that disease? And this could just be the prevalence of the disease in the population from which the patient comes. You know, if 20% of people in a population have strep throat, say, the prior probability of someone from that population having strep throat is 20%, or 0.2, 0.2, 2/10, or 20%, okay? And then this term down here is the evidence. It is the test we are performing and getting a result from. Once we have the results of that test, it is objective evidence that we hope will refine our understanding of how likely our diagnosis is. And we hope that it makes our diagnosis overwhelmingly likely so that we can feel confident in the diagnosis of the patient and therefore in the treatment we choose for them. Okay, I hope it helps to look at this equation from a few different angles to build understanding, okay? All right, now this is a chart you guys should be very familiar with, and I'm including it just to remind you of these things. When you take board type examinations, certainly the USMLE, which I'm more familiar with because I'm American, you really always want to draw one of these tables on your scratch paper first thing, just to help you work through the inevitable few problems there will be on this topic. So, you have the chart. In this row, in this row are all the people who are testing positive, and in this row are all the people testing negative. Up here are all the people who have the disease. So this column is everybody who has the disease. The people who have the disease and test positive, the true positives, and the people who have the disease but test negative. They're the false negatives. They test negative, but they actually do have the disease. On this side, you have they do not have the disease. Some of those people will test positive, right? And those will be false positives. They have a positive test, but they do not have the disease. And then lastly, you have the true negatives. They don't have the disease and their testing is negative, okay? So we use these to calculate sensitivity, which is the proportion of people who test positive out of all the people who have the disease, right? Both the true positives, which are A, and the false negatives, which are C, these people down here, right? Because you want to know how many people can I detect who actually have the disease out of all the people who have the disease, right? How well is the test performing? And this is why we want screening tests to be very sensitive, because we want to catch all of the positives, okay? Specificity is also a very important characteristic of testing. Specificity is measuring of all the negatives, those who are truly negative and falsely positive, how many of them, out of all the negative tests, are the true negatives? They test negative and they don't have the disease, right? And you can, again, look up the chart to see what the D and D plus B mean, but they all stand for each element of this. So you guys are more familiar with those probably. And again, we want to test with specificity when we want to make sure someone doesn't have the disease. In other words, when the test is negative, we can be confident the patient doesn't have the disease. That's how we use specificity. It's how we use sensitivity. If the sensitivity is high, we suspect that if there's a positive test, we are capturing all of the positives with that test. The problem is, of course, there are always going to be false negatives, right? We'll never catch them all. And when you have a very high sensitivity, it means you're more likely to catch positives that are false positives, right? It's more sensitive. It's picking up all the positives. All the positives. And the same thing with specificity, they're picking up all the negatives. So these, the positive predictive value and negative predictive values, briefly, because this isn't really what we're talking about, but just reviewing to help us as we move forward. The positive predictive value is saying, boy, if you have a positive test, in other words, you test positive, you're in this row of the chart, if you have a positive test, true or false, how likely is it to be real? In other words, how predictive is that test of someone actually having a disease, right? So if you have a bunch of true positives, but also a bunch of false positives, it's not going to be very predictive. A positive test doesn't help you know the patient has a disease if the positive predictive value is low. Same thing for the negative predictive value. If the test is negative, but the negative predictive value is low, that doesn't help you very much because a negative test doesn't necessarily mean the patient doesn't have the disease. Now, these are affected, of course, by the sensitivity and specificity in a way, whereas sensitivity and specificity are not generally affected by the prevalence of the disease, positive predictive value and negative predictive value really are. In other words, in a population where the prevalence is high, a positive test means a lot more. It means the patient's more likely to have the disease than in a low prevalence population. And the same for negative predictive value. Okay, prevalence matters. Okay, so let's talk briefly about these likelihood ratios that I mentioned. Think of them in the same category as sensitivity, specificity, positive predictive value, negative predictive value. This is the likelihood ratio. And all this is saying is we're looking at the probability, and again, okay, there's positive and negative, okay? So the positive likelihood ratio is the probability that a test is positive in diseased persons divided by the probability that a test is positive in non-diseased persons. These are the so-called false positives. So it's really the sensitivity divided by 1 minus the specificity, because we're looking at non-diseased persons. That's why we're looking at the specificity. 1 minus the specificity is, specificity is the true negatives out of all the negatives. So 1 minus that is the true positive the test being positive out of all the negative people, okay? Or all the people without a disease. Sorry, I don't want to get you guys more confused because my language is confusing. So the positive likelihood ratio says, I have a test that's positive. What's the probability that test is positive in diseased people versus being positive in non-diseased people? We want a high positive likelihood ratio for a test. If it's positive, we want that to show us this is a diseased person. This is how you calculate it. That's why I showed that other chart before I showed you this, so that you'd be able to calculate likelihood ratios. Though again, not very often in medicine do we calculate the likelihood ratios ourselves. We often look those up because other people have already done those calculations for us, okay? Negative likelihood ratio, very similar, of course. It's the probability that a test is negative in a diseased person divided by the probability the test is negative in non-diseased persons. So what we want is a very low negative likelihood ratio, right? If the test is negative, we don't want it in diseased persons. We want positive tests in diseased people. So we're hoping that not very many of the tests are negative with diseased people. And we're dividing that by the probability that the test is negative in a non-diseased person, which is what we want. Okay? So we want a low numerator in this case and a high denominator. We want to calculate it using 1 minus sensitivity for the top over specificity. We want a very specific test. Or in other words, sorry, I just said that. We want to calculate it by the 1 minus sensitivity on the top. Sensitivity being the true positives out of all the people with positive tests. Okay, going back to this. Sorry, out of all the people with the disease. Okay. And then we're going to divide that by the specificity of the test. So again, how likely is it that a negative result means they don't have the disease? How likely is it that a positive result means they do have the disease? Okay, that's how you're going to use those. Hopefully that clear all that stuff I just said. If it's not clear to you, you don't really have to know that. It's good to know how to do this basic calculation because it combines things you know how to calculate already, so it makes it easy for you. If you have that data available to you, it's very simple to calculate the likelihood ratios. At the same time, you can always look up likelihood ratios for various tests, and very often you can find those. If you don't find them, you know the subject of your next research paper is to go ahead and identify those for a specific condition and entity you're considering. Okay, this is what I was saying about looking it up. So as one example of a place where you can go look some of these up, the NNT.com. NNT is the number needed to treat. It's the cutesy name for their website that has a lot of, as they say, quick summaries of evidence-based medicine. Okay? The NNT.com is a place you can go look up likelihood ratios for some common conditions. And they also have great evidence summaries of other things, helping you think through what is the evidence basis for this condition I believe my patient has. How do I need to understand the evidence that's out there already? These people have summarized it for you, which is really nice. So again, you don't always have to calculate likelihood ratios. Sometimes you can just look them up. And in clinical practice, that's definitely what happens much more commonly. If you're reading a research paper, a clinical study, then okay, it makes more sense to calculate those yourself. And maybe they do it for you in the context of the study. You may want to verify their calculations because it's not impossible that a peer-reviewed journal publishes a false calculation from time to time, even the very good ones like the New England Journal of Medicine or the Lancet or the BMJ. It happens. So anyway, you can look up likelihood ratios is all I'm trying to say there. So again, we're going to look at things from a few different angles to help you guys understand likelihood ratios. So as I said, a positive likelihood ratio, we want it to be high. In other words, we want it to be way more than 1. We want when we have a positive test, we want to have high confidence that the person has the disease, okay? So when you have a high positive likelihood ratio, it means that your chance of having that disease, given a particular test with a high likelihood ratio, is much higher, right? So if I have a moderate probability of somebody having the disease and they have a test performed that has a high positive likelihood ratio, if it's positive, we can be very confident they have the disease, right? And negative likelihood ratio works the other way. The lower it is, the more confident we can be that a negative test really represents the fact that they do not have the disease. And it makes a big change in your pre-test probability. We'll look at that graphically in a second. But if I think there's a moderate chance, a 20% chance, a 30% chance my patient has the disease, and they have a negative test, and the test has a very low, in other words, much less than 1 likelihood ratio, then I can be pretty confident my patient does not have the disease, okay? Now, you have more moderate shifts with lower numbers. Again, we're getting closer to 1. Moderate shift with numbers that aren't quite as strong as the first row. Even getting closer and closer to 1, you get small shifts, but those could be important. Again, where you have more of an intermediate probability, or in a case where you have a pretty low probability entity. You could see small but significant shifts in the chance that someone has a disease. If it's a very serious disease and there's a small shift toward them having the disease, then we're going to take that more seriously, even if their pretest probability was relatively low. And again, we're going to look at all this graphically as another way of looking at it in a second. Similarly, the closer I get to 1 going the other way, coming up toward 1, I'm getting small but important shifts sometimes in the likelihood they don't have the disease. Okay? And here, where the likelihood ratio for the positive is 1 to 2, positive likelihood ratio of between 1 and 2, or a positive likelihood ratio between 0.5 and 1, they really don't alter my pretest probability of the disease very much. In other words, it's kind of a useless test. The test did not help me. It doesn't change the probability that my patient has the disease in the positive likelihood ratio case. It doesn't change the probability that my patient is free of disease in the case of the negative likelihood ratio. It just doesn't help me very much. Okay? So in terms of the operating characteristics of a test, we're looking for high positive likelihood ratios. When it's a positive result we're examining, we're looking for very low, again, much less than 1 results in likelihood ratio on the negative side when we're wanting to know that a patient of ours with a negative test does not have the disease with certainty. Okay? Again, just trying to look at it from multiple different ways. I gave you the math-heavy way of looking at it. I've given you the table and computational way of looking at it. I've given you it written out in text, and now I've given it to you in this chart form. So again, be able to describe these things to yourself and to your friends with words, with a paragraph, right? You don't have to understand the math, although it may help a lot of you understand what's going on. But you do need to describe the meaning of these concepts to yourself and to others. That will enable you to use them. Okay, so one last way of looking at likelihoods. This is akin to me saying, hey, you don't have to calculate all the likelihood ratios. You can look those up. This nomogram, which you'll find everywhere, means that you don't have to always calculate Bayes' theorem. Okay? This is going to do that for you. How does it do that? Well, in the first column, you have the pretest probabilities. The second column is the likelihood ratio, and the third is the post-test probability. So this is the probability of A given B. This is your likelihood, again, that top part, that numerator part of Bayes' theorem. This is the pretest probability, also in the numerator of Bayes' theorem. Okay? How do you do it? So let's just look at this. The pretest probability of my patient having a disease is, let's say, 20%. We'll look at this again. Let's pick 50%. 50%. And they have a positive test. The positive likelihood of that test, the likelihood ratio, the positive likelihood ratio, let's say is 2. So I'm going to draw a line with a ruler through 2 from 50% and see where that line lands in terms of post-test probability. So I'm going from a 50% pretest probability of having the disease with a positive likelihood ratio of 2 up to about a 60% chance with a positive test that I have the disease. You can see that a 2 doesn't change the post-test probability very much from the pretest probability. 50 and 60% aren't that far apart. Now that can be a meaningful difference clinically for sure, but just know that you can just see graphically played out a number of 2 doesn't really change your probability of having the disease very much. Whereas if I'm 50% likely to have the condition, if my likelihood ratio is 10, like we were saying, all of a sudden I'm upwards where if I have a positive test, I have a 90% chance of having the disease. And this is really important because we think of sensitivity and specificity as if a test is sensitive and you test positive, you have the disease. No, that's actually not so, right? That's actually not so. It just means you have a good chance of being caught by the test if you have the disease, therefore more testing needs to be done, right? It doesn't mean you have the disease. It means we caught a lot of true positives and a lot of false positives, and we need to now do more testing to figure out if that's a true positive that I came up with my sensitive test or a false positive, right? This likelihood ratio is getting you more towards what is the truth, what is the real result. What does this test mean for my patient's likelihood of having the disease? All right, so we'll go through some more concrete examples in the next portion to help you guys understand this stuff. But I hope this look at Bayes' theorem and likelihood ratios has really helped you at least begin to develop an understanding of the concept of what is Bayes' theorem doing, what does a likelihood ratio mean, how does that help us be confident in our diagnosis of a patient or in ruling out a diagnosis in a patient. All right? And we will go next to the last lecture. I will see you again for a third lecture to finish out this topic where we practice applying Bayes' theorem, Bayesian reasoning, Bayesian inference to clinical problems and see how it affects what we find as we deal with patients. So again, the thing you need to understand from the first lecture is just basically what is this thing called Bayes' theorem, okay? What you need to develop in the second lecture is a more in-depth understanding of Bayes' theorem and where it comes from, why it works, and also of likelihood ratios. What do they mean? How do we use them? Again, just basically, we haven't done very much. We'll give examples to help you practice in the next lecture and then possibly in a homework assignment. But for now, those are the big things. Understand basically what Bayes' theorem is talking about, first lecture. Second lecture is a little bit more of the math and looking at things from different angles so you can understand in more depth where does Bayes' theorem come from, why does it work, and how do likelihood ratios play into that? What do they mean? How do we use them? How do they play a role in Bayes' theorem? Okay, I will see you guys for the third and final lecture on this topic in a minute. Thanks.